Biologics and Biosimilars in CTDs. Let's talk about a very important and rapidly growing area in rheumatology and dermatology practice. Biologics and biosimilars in connective tissue diseases. Biologics. What are they? Biologics are not like ordinary chemical drugs. They are made from living cells, often engineered to produce monoclonal antibodies or fusion proteins. Instead of broadly suppressing the immune system, they act on specific immune pathways. That means less scatter, more precision. Example, take methotrexate. It reduces inflammation but affects many cell types. Now compare that with a TNF inhibitor. It blocks only tumor necrosis factor, a key inflammatory cytokine. This targeted action often gives better control in resistant disease and sometimes with fewer side effects. Common biologics by disease number 1, rheumatoid arthritis and overlap syndromes. This is where biologics really transform treatment. The most well-known are the TNF-alpha inhibitors, etanercept, infliximab, adalimumab, golimumab, and certolizumab. These drugs directly block TNF, a molecule driving joint inflammation and damage. Example, a patient with RA who's been on methotrexate for months, but still wakes up with stiff, swollen fingers. Adding adalimumab can dramatically reduce pain, improve mobility, and protect joints long-term. Then we have the IL-6 blockers like tocilizumab and seralutinib. They are especially helpful in patients with high systemic inflammation, weight loss, or anemia due to active disease. Rituximab is another powerful option. It targets B cells, which play a role in autoantibody production. And finally, abatacept, which blocks T-cell co-stimulation, is useful when other biologics fail. Together, these agents give us multiple options to tailor therapy depending on patient profile and comorbidities. Number 2, systemic lupus erythematosus, SLE. This is more complex. The first biologic officially approved for lupus was belimumab. It blocks BAFF, also called BAFF, a factor that promotes B-cell survival. By reducing abnormal B-cell activity, belimumab decreases lupus flares. Example, a young woman with recurrent rashes, joint pains, and fatigue, despite HCQ and steroids. Adding belimumab helps lower steroid dose and keeps her stable. Rituximab, although not formally approved for lupus, is widely used in practice, especially in severe kidney involvement, lupus nephritis, or in central nervous system lupus, where standard drugs may not be enough. And recently, anifrolumab was introduced. It targets the type 1 interferon receptor. Why is this important? Because interferon signaling is one of the key drivers of lupus inflammation. Number 3, systemic sclerosis, or scleroderma. This disease is known for skin tightening and lung fibrosis. Here, rituximab and tocilizumab have shown promise in improving skin thickness and slowing down lung disease. And for interstitial lung disease specifically, nintedanib is often used. Though technically not a biologic, but an antifibrotic, it helps slow down scarring in the lungs. Early introduction of these drugs can prevent irreversible lung damage, which is one of the major causes of disability in scleroderma. Number 4, dermatomyositis and polymyositis. These are inflammatory muscle diseases. We start with steroids, but long-term high doses are harmful. That's where biologics come in. Rituximab is used for resistant myositis, especially when patients don't respond to methotrexate or azathioprine. An IV immunoglobulin, IVIG, is a proven treatment for severe dermatomyositis, particularly when both muscles and skin are badly affected. Example, a patient with dermatomyositis unable to lift arms due to weakness and with painful skin rash. IVIG often leads to dramatic improvement. Number 5, Sjogren's syndrome. This mainly causes dry eyes and dry mouth. While artificial tears and saliva substitutes are first line, in severe cases with vasculitis or neuropathy, rituximab may be considered. It helps by reducing abnormal B-cell activity driving systemic disease. Number 6, antiphospholipid syndrome. The mainstay here remains anticoagulation with warfarin or heparin. But in rare catastrophic APS, where multiple organs clot at once, biologics like rituximab or complement inhibitors such as eculizumab have been tried with success. These cases are uncommon, but they highlight the expanding role of biologics even in clotting disorders. Biosimilars and CTDs. Now let's talk about biosimilars. What are they? They are highly similar versions of approved biologics. They have the same clinical effect, the same safety, but are produced by different manufacturers once the original patent expires. Stress word. The most important point is cost. Biosimilars are often 30 to 50% cheaper than originator biologics. This makes them accessible to far more patients, especially in middle and low-income countries. Examples include rituximab biosimilars, which are widely available. Etanercept, adalimumab, infliximab, and tocilizumab biosimilars are also entering markets globally. Key points before starting biologics or biosimilars. Always remember, screen for tuberculosis and hepatitis B or C before starting. Update vaccinations, especially for flu and pneumococcus. Check baseline blood counts, kidney and liver function. And during treatment, watch closely for infections, infusion reactions, or unusual lab results. Slow tone emphasize. These drugs are powerful allies, but require careful monitoring to be safe. Dr. Yogesh summarizes biologics are precise, targeted treatments that have changed the way we manage connective tissue diseases. They give hope to patients who previously had limited options. Biosimilars are equally effective but much more affordable, helping expand access worldwide. The most widely used biologics and CTDs are rituximab, belimumab, tocilizumab, and TNF inhibitors. Each has its own role, from controlling arthritis to protecting kidneys to slowing lung fibrosis. The ultimate goal remains simple: control inflammation, protect organs, minimize side effects, and improve quality of life. And that truly is the promise of biologics and biosimilars in connective tissue diseases.